Hello. My name is Dr. François Ricard. I am an osteopath and a PhD. I am director of the International Madrid School of Osteopathy, EOM, and president of the Scientific European Federation of Osteopaths, SCFO. In this video, I want to talk to you about the mechanism of action for HVT used to treat pain. This series of videos will look at the scientific literature surrounding the mechanisms of spinal manipulations, mostly used by osteopaths and chiropractors. In these videos, we will study the mechanical mechanisms of action for disc hernias, the effects they have on the peripheral and central nervous systems, the neuromuscular, biological, and neurovegetative systems, and on the organs. In this video, we are reviewing the effects of spinal manipulations on pain. The results of the study by Fernández de las Peñas et al., 2008, suggest that a C71 manipulation produces changes in the pressure pain threshold of the right and left C5-C6 zygomatophyseal joints in healthy subjects. Subgroup analysis by Coronado et al., 2012, showed a significant effect of HVT on increasing pressure pain threshold at the remote sites of stimulus application, supporting a potential central nervous system mechanism. According to Fryer, after applying osteopathic manipulative treatment, both biological and psychosocial treatment mechanisms affecting the tissues, nervous system, and psychology of the person may help modify pain and increase movement, though improvements may be small and temporary. These mechanisms may help to improve cognitive reassurance and education to help with motor control. This picture shows the psychosocial and biological factors in somatic pain and aims of osteopathic management, according to Fryer. Paget et al., 2019, observed a decrease in pain intensity, disability, and tenderness during spinal manipulation. P-values less than 0.05. At follow-up, 24% of participants were classified as improved. Predictors of improvement were a greater decrease in pain intensity and in tenderness, p-values less than 0.05. This figure, according to Paget et al., 2019, shows in A, spinal manipulative therapy parameters. In B, muscle activity, pale bars, median plus minus IQR, and indenture displacement, dark bars, mean plus minus standard deviation. This model, according to Bielowski et al., 2009, provides visualization of potential individual mechanisms of manual therapy that the current literature suggests as pertinent, and provides a framework for the consideration of the potential interaction between these individual mechanisms. Specifically, this model suggests that a mechanical force from manual therapy initiates a cascade of neurophysiological responses from the peripheral and central nervous system, which are then responsible for the clinical outcomes of reduction of the pain. In this study by Spinal et al., 2019, change in pressure pain threshold after spinal manipulative therapy, compared to sham, revealed no significant difference. Pressure pain threshold increased significantly over time after spinal manipulative therapy, 0.32 kilograms per square centimeter, CI 0.22 to 0.42, which occurred systemically. They found that systemic manipulation induced hypoalgesia from pressure pain threshold does occur in musculoskeletal pain populations, though there was low-quality evidence of no significant difference compared to sham manipulation. Future research should focus on the clinical relevance of manipulation-induced hypoalgesia and different types of quantitative sensory tests. This figure shows the forest plot of pressure pain threshold change from baseline after spinal manipulative therapy, in descending order of study quality. Coronado et al. 2012 showed that spinal manipulation demonstrated a favorable effect over other interventions on increasing pressure pain threshold. Analysis of the subgroups showed a significant effect of spinal manipulation on increasing pressure pain threshold at the remote sites of stimulus application, supporting a potential central nervous system mechanism. The picture shows the measure of pressure pain threshold in low back pain. The findings of the study by Prinsen et al. 2014 suggest that analgesic medication use is lower in patients who receive OMT, align with previous findings of randomized controlled trials, and support the generalizability of these findings. This table shows the improvement measures in 539 patients who underwent one osteopathic manipulative treatment session versus those who did not. The objective of this study by Oliva Pascual-Vaca et al. 2017 was to determine the efficacy of a high-velocity low-amplitude manipulation of the thoracolumbar junction in different urologic and musculoskeletal parameters in subjects suffering from renal lithiasis. Intragroup comparison showed a significant improvement for the EG in the lumbar flexion range of motion, p less than 0.001, and in all the pressure pain threshold, p less than 0.001 in all cases. Between group comparison showed significant changes in randomized controlled trials in quadratus lumborum, p less than 0.001, as well as in the spinous processes of all the evaluated levels, p less than 0.05. No changes in urinary pH were observed, p equals 0.419. Spinal manipulation of the thoracolumbar junction seems to be effective in short term to improve pain sensitivity, as well as to increase the lumbar spine flexion. According to Thompson et al. 2009, neither spinal HVT nor mobilization had a significant effect on randomized controlled trial of the lumbar spine in asymptomatic subjects. Only spinal mobilization appeared to have a greater mean increase in pressure pain threshold and effect size than the control group. In the study by George et al. 2006, hypoalgesia from spinal manipulation was observed in lumbar innervated areas, but not in control cervical innervated areas. Local dorsal horn mediated inhibition of C fiber input is a potential hypoalgesic mechanism of spinal manipulation. The results of the study by Mohammedian et al. 2004 suggest hypoalgesic effects following a single spinal manipulation. The hypoalgesic effects appear to be caused by central mechanisms. According to Vicenzino et al. 1998 and 2001, manual therapy produces a treatment-specific initial hypoalgesic and sympatho-excitatory effect, beyond that of placebo or control. The strong correlation between hypoalgesic and sympatho-excitatory effects suggests that a central control mechanism might be activated by manipulative therapy. This diagram shows changes in pain-free grip strength and pressure pain threshold of the affected side expressed as a percentage change from pre-application for treatment, placebo, and control conditions. Mean plus minus standard error of mean. Conclusions. Spinal manipulations reduce pain. Changes in pressure pain threshold after manipulation were observed in multiple studies. The hypoalgesia produced seems to be mediated by the neurovegetative and central nervous systems, as is the secretion of biological substances. Here you can see a list of all the references used for this presentation. Thank you for listening.